Hello, everyone. Thanks very much to NeuroNews for inviting us today. My name is Mayank Goyal, and I'm here at the Calgary Stroke Program in Calgary, in Alberta, in Canada. And along with me today is Johanna Ospel. Johanna is a resident who decided to come and spend a year with us here at the Calgary Stroke Program, and it's been a pleasure to have her here for the last 1 year. And today we're going to be talking about a whole bunch of issues related to stroke care. Welcome, Johanna.
Thank you.
So as you know, right now it's very difficult to talk about anything at all in any part of the world without talking about COVID. And the first thing that we do have to realize is that all of us are dealing with COVID, but at the same time, that has not made stroke go away. Stroke is still there, and we still need to take care of stroke patients. And in the meantime, we have to prepare ourselves to be able to optimize stroke care, optimize fast and efficient delivery of treatment, even in those patients who either are clearly COVID positive or suspected COVID positive. And every institution around the world is taking steps along this pathway to be able to sort of ensure that firstly, they can deliver this care efficiently. And secondly, they don't end up spreading the disease to healthcare workers and keep healthcare workers safe. So why don't we start with talking about that a little bit from different perspectives around the world that we are working with. So Johanna, why don't you expand on it a bit, and maybe we can talk a little bit about what all steps should be taken or have been taken in this regard.
Sure. Yeah, so I think COVID is definitely a challenge for every hospital or every stroke service around the world, but the challenges different hospitals are facing in different parts around the world are different. And everywhere there are a lot of new regulations and new protocols released in rapid succession, and it seems that everyone is a little bit confused because you have to take on new roles. Suddenly there are things to consider that haven't been an issue before. So until COVID has become an issue, we actually didn't pay too much attention to infectious disease control or particular hygiene rules in stroke care, and suddenly we have to. And that's new, and that's a challenge for every one of us. And we do think that practicing these new regulations and protocols is very helpful in order to feel safer as a healthcare worker, but also to be more efficient and to get used to all those new regulations, to avoid confusion, and in the end to open the vessel faster or to treat the patient faster and improve outcomes.
Yeah, I think this is absolutely important. In fact, we were just yesterday talking to some friends and colleagues in Norway, in Stavanger, and they in fact started running simulations where they had a, so to speak, actor act as a COVID positive situation and brought in by an ambulance by paramedics. And then they ran through the whole simulation in terms of who's doing what. And one interesting thing that they pointed out to us was the degree of decrease of apprehension of the workers after the simulation process, where everyone felt like they knew what they needed to be doing. They knew what was safe to do, not safe to do. Not to mention the fact that you're working with PPE, you should be able to wear it on quickly, but at the same time, do it appropriately, not be touching the outside of your mask, for example, and then know how to take it off in a way as well. One of the things that we've done at our institution is that, for example, for an endovascular thrombectomy, we've created 2 teams. We have a dedicated room now for suspected COVID patients. And we've created 2 teams. One team is inside the room, which is fully donned in sort of PPE, and they remain inside. And the team that is outside remains outside and takes care of all the other stuff. The 2 teams talk to each other, but realistically speaking, don't come in touch with each other. Now, obviously, we had to prepare for this, in which the team that is inside and the team that is outside is outside. But the other interesting thing that we were able to do is, so to speak, standardization of approach, where we know exactly what we're going to need for a thrombectomy procedure. And we're not running around last moment where the team is on the inside, but they don't know where what is, and they're trying to look for stuff. So to speak, a standardized approach through a thrombectomy and a standardized way of setting up things. And in fact, I've been talking about this for many, many years, what I call the BRISC kit, BRISC recanalization ischemic stroke kit, where everything is set up in a standardized kind of way. in which you sort of know you use the same thing every time sort of thing, in which case there's less amount of variance. But in the era of COVID, that had the additional advantage of that the team that is inside knows exactly where what is, they know what is going to be needed at what time, and there is less likelihood of the team on the inside needing stuff from the team on the outside. So that is one tiny little step that I think can be taken into account, which would further sort of increase efficiency and reduce stress on the system. Another interesting thing that we found useful to do, and which many institutions are doing, is, so to speak, a post-mortem after the case. What did we do wrong? What would we have done better? Did anyone feel like that they didn't know what they were supposed to be doing? Did they have any apprehensions? Talk with your entire team at the end of every case. And I do find that document it, spread it to the rest of the team. And that's another step that I think will go a long way, not just only towards sort of reducing apprehension, improving care, but also towards, so to speak, the team approach and keeping everyone together through these stressful times. So what we think is, we would strongly recommend that firstly, we need to strongly endorse the idea that we are open for business. We are open for business in terms of we will take care of stroke patients as we have always done in this COVID era. The second thing is, we would strongly encourage all of you out there in your respective teams to sort of work with your team, think about simulation, think about practice runs, and think about sort of not just doing it once, but doing it again and again to continue to sort of improve. And at the same time, I do think that this is just how it is, that we will along the way get affected. I'm in a recovery phase right now. I've been in isolation for the last 9-10 days or so, and I'm sort of coming out of it. Yeah, that is going to happen, and we'll see people around us who will fall sick and recover and come out of it, and we'll move on.
It's absolutely normal, I think, to not know what to do right now, and that's nothing to feel concerned about or be ashamed about. That's completely normal, and that's why we suggest to actually run through those protocols, and because everyone is confused. That's not an exception, that's the norm right now, I guess.
Yeah, that's a good important point. That's an important point. And the other part that is there is, like just the other day, I was doing something wrong in terms of sort of taking off my mask, and this junior nurse pointed out to me that this is the right way of doing it. So there is no such thing as seniority or juniority or whatever the word is. Just work together, learn from each other, and let's keep moving on. But at the same time, though, moving topics a little bit, like it's right now 2020, or sort of 1/4 of the year done in 2020, and 2015 is when endovascular treatment became the standard of care. And it's 5 years now. And in 2015, all the guidelines changed. And at that time, sort of across the world, whether it's in US or in Canada or in Japan or anywhere else, it became standard of care, and that was major news. And since then, in addition, a whole bunch of additional data came out. And it's tough right now to find a subgroup where endovascular treatment does not work. But at the same time, we've sort of 5 years out now from when it became standard of care. So Johanna, what do you think? What is your report card for the world? Do you think the world has done a great job in 5 years from something that is such a powerful treatment effect and great for stroke patients? Or do you think sort of what kind of marks would you give the world in terms of implementing endovascular treatment and taking care of stroke patients due to large vessel occlusion?
I think the world has done a pretty good job at it, and I think you've played a significant role in it. And I think there is still potential for improvement, but overall, it's a little bit of a glass half full, glass half empty situation, I think. Like, I think that in 2015, when EVT suddenly became, or it has been shown that EVT is effective and it finally became standard of care, we were facing a situation that wasn't as extreme as COVID right now, but it was also new, because suddenly a whole network of EVT centers had to be established in order to offer EVT to every stroke patient. And that's actually a huge effort in terms of infrastructure, in terms of staff requirements and yeah, just hospital networks that had to be adapted and rearranged. And I think now we're actually pretty good because in large parts of the world, at least in the industrial nations, EVT is offered quite to most patients actually. And there are still spots where it is harder to receive EVT or where transport times are longer, for instance. But I think we're working on improving that, and that's obviously not easy because you cannot just decide to build a hospital in the middle of nowhere. There are a couple of things to consider, which you might know better than I do. But overall, I think we're slowly working to even to improve stroke care even more, and we're actually already doing a pretty good job at it. What do you think?
Well, I think the part about once a patient with a large vessel occlusion comes to an endovascular capable hospital somewhere on the planet, I think that part from there on, we've done a very good job. We've continued to improve workflow. We've continued to have better training of the entire staff, not just neurointerventionists, but whether it's nursing staff, emergency staff, imaging staff. We've continued to make imaging protocols easier and simpler and more efficient. We've continued to have innovation in our tools that are available in the intervention suite. We've continued to improve on our technique and training so that we can get to the relevant clot faster and open vessels faster. So that part, I think we are doing a phenomenal job in terms of sort of over 5 years showing improvement. The part where we need to work is getting the correct patient to the correct hospital as quickly as possible. And that actually is a little bit more of a complicated problem. So that has two issues of it. One is correct patient, and the second is correct hospital. So how do you know who's a correct patient? And right now, to know that the patient is, so to speak, a correct patient, the patient needs to have sort of imaging like a CAT scan or a CT angiogram. But that means you're already at hospital of some kind, which has a CT and a CT angiogram available, sort of thing. So that raises a sort of a catch-22 kind of problem. And that is where I think there will need to be improvement in education at the level of paramedics, but also lots of innovative solutions are being worked on. Where will there be tools at the level of the paramedic or ambulance in which the tool can be used by the right where the patient is to decide, is there a likelihood of this person having a large vessel occlusion, so that this person can be taken straight to an endovascular capable center. And we'll just have to see how that story sort of plays out. And obviously it'll have to be backed by data and evidence. There is a trial running in Barcelona called the Racecat trial, which is sort of trying to see whether a pathway of primary stroke center followed by comprehensive stroke center is better, or going straight to the comprehensive stroke center is better. But there's also this other issue that is there, is this idea of what should an endovascular capable center be, and how many centers should there be in a particular urban area? Should it be sort of free for all, in which, you know, in the Los Angeles area or in London, you can have 50? Or should you divide it up by zone, that for every million population or 1.5 million population, there is one centralized center where everyone is brought in and they're busy and they're efficient and they take care of stuff? That's another issue that I don't think we know a very good answer for. And very often that is decided generally by your healthcare system. So in Canada, for example, we have much more of a centralized healthcare system, or in the UK or in Switzerland, but there are other places where it's much more of a sort of a free market healthcare system where everyone is allowed to offer services and compete with each other. And again, I'm not sure which system will ultimately play out, which system is best from a patient perspective. And for that matter, even if suppose one system is better than the other, whether there is or there should be any capacity to control it. So do you have any sort of views on what can be done in terms of sort of organization of stroke care?
So I think one important point would be to establish proper standards for endovascular capable centers. So it's important, I think, to make sure that at least in areas where it is possible that neurointerventional fellow trained physicians are treating patients. And I think one thing is also clear, that sometimes people say that everyone should just come to an endovascular capable center, but at least at the current moment, I think this is also not a good solution, because EBT centers will just get overwhelmed. And I think there is a role for primary stroke centers. It's just not clear sometimes what that role is, or there are a lot of arguments, and I think it's important to clearer define that role, actually. What do you think?
Yeah, I think that's an important point. But I do think, though, that the first thing that we need to understand is that we have paucity of data. We have paucity of data of people who are not treated. And I have written extensively on this topic of that we need better data on the total number of large vessel occlusions that occur in a particular jurisdiction, and to be able to sort of follow them to see what exactly happened, which were the ones who got treated, the ones who did not get treated, why did they not get treated, the ones who even did get treated, what were the reasons for the delay. And as an example, we are trying to set up a study which we call the denominator study, which we are going to look in Alberta, which is the province where we live, which has got a population of around 3.1 million or so, and go back and see that based on healthcare records, say, for example, in 2018, how many were the total number of large vessel occlusion strokes that occurred, and out of that, how many underwent endovascular treatment. So as a starting point, I do think that there should be sort of better registries, better data to sort of figure out exactly what is happening in your jurisdiction. I do not think that there is one standard solution that will fit Los Angeles and would fit Mumbai or Beijing or London, or for that matter, a medium-sized city. Each one will have their unique perspective, and they need to have sort of centrally mandated, probably better collection of data to know where the bottlenecks are. And once we have an understanding of bottlenecks, then we can start to sort of solve those bottlenecks to the best possible based on sort of resources available. I do think that getting into brain vessels and pulling the clot out is something that you shouldn't be doing like a tourist. You should be doing it day in, day out. You should know stroke care. You should know about the rest of the brain functioning. You should know that if you try to open the M1 and the clot breaks away and goes into the anterior cerebral artery or the distal M2, what you're going to do, is it worth going after it or not, how to do it safely. All those things are important, even though sometimes, YouTube videos make it look like to just get in there and pull the clot out kind of thing. You do have to be prepared for the rest of it. And the other part, which sometimes I do think people underestimate, is the importance of the team, the importance of a stroke unit, the importance of a comprehensive care of the patient, on follow-up, give them proper rehab, swallowing tests, so on and so forth, that are taken care in a stroke unit. So I do think that we need to have better collection of data, and that is potentially where governments or the societies and all can work together to sort of have that collection of data available. And then once that data is available, to use that data to see how do we sort of optimize the process of stroke care delivery. And in 5 years, we made so much improvement in terms of opening the vessels. But now how do we do it that at a population level, we just have greater penetration of this treatment, and we are able to get sort of the correct patient to the correct hospital the first time around, to be treated by a team. And I stress on the word team. I do think that puncturing the groin, getting to the carotid, and opening the vessel is a small part of the patient's journey from having a severe stroke to recovery, where they're taken care by a team who knows what they're doing, and that is what they do day in, day out. That I think is critical if we are able to continue to make further substantial improvements in stroke care. We'll continue to do innovative new research, whether it is in the detection of LVO in the field, whether it is on sort of preventing neurons from dying while we go and open the vessel, like we did in Escape NA1, and we now hope to start the same trial again to re-demonstrate or be able to show conclusively that the results in Escape NA1 were not to validate them. I'll tell you more about that in a moment. But at the same time, sort of continue this, so to speak, idea of a worldwide research network to sort of recognize a problem, tackle it, see what the solution for it, go test it, and sort of show that the solution that we found is worthwhile and reproducible. From the perspective of, since you're in your training period, what do you think from a training perspective, thinking about the next sort of 5 to 10 years? Do you think there should be changes that should be made in the way that the next generation of stroke doctors are being trained in light of everything that has happened in the last 5 years?
I think there should be a lot of changes actually. I sometimes look at aviation industry and think about how pilots are trained, for instance, and they're going through a lot of simulation training before they fly their first plane, and actually no one is asking them who was your instructor or where did you train exactly. But in our field, it's still a pretty big deal if you trained with, let's say, René Chapeau in Essen or some other famous guy in Paris. So there seems to be a lot of dependence on the place where you trained, or there's a lot of emphasis on that. And I think it's in what we are doing is we are actually training in a patient. So we learn our skills while performing a procedure in a patient. And we also make our first mistakes in a patient. And the whole learning curve is basically taking place in patients. And aviation industry somehow managed to take that out of the human environment. They now train in a simulation environment. And right now we have simulators, but they're not as good as they could be. But that's probably also because there is some kind of skepticism with regard to simulators from the side of physicians, because they are saying we're finally treating patients and we're not treating engines, so we want to actually also train in a patient. But I think simulation training would be one very important point that I would appreciate having as a fellow. And I also think it would kind of equalize the differences, because if you're in a shitty place where your staff doesn't show you anything, then you have no choice but sucking at what you're doing, basically. But if you had the chance to independently train with the means of simulation, for instance, you could manage to become a very good neurointerventionalist even without good supervision, I guess. So that would be another important advantage. And I'm very sure I will have good supervision in Calgary, but I'd still appreciate a simulator training program. So
yeah, that's a good point. That's a really good point in terms of the evolution of the airline industry vis-a-vis the medical industry, and how the medical industry has been relatively slow in catching on to the usefulness of simulation. And partly we are stuck in the trap of that doctors say simulators are not good, so what's the point of using them? And simulators are not good because doctors are not using them. So, we're stuck in a circular trap. And hopefully we'll find a way through technology, or through reduction of costs in simulators, or through industry support, or through a general change in culture, where it'll be part of the training paradigm, which I'm pushing for quite hard. And we've just had an article accepted in Stroke on this idea, which you'll see in print shortly. So I do think that is a very important point in terms of the increasing role of simulation to, so to speak, varying the gap of training. But I personally am increasingly of the belief that it's just not just in training. It should be something which is lifelong. It should be lifelong utilization of all resources that are available to you, for you to continue to improve your skill set, whether it is new devices, or whether it is new techniques, or whether it's just plain and simple that, right now more and more people are going through the radial approach, and maybe there'll soon be excellent simulation environment for you to reduce your learning curve of as you come up the radial kind of thing, compared to femoral, and everyone should be using those simulator tools to do that as well. But I do think, yeah, all the points, Johanna, you make are really valid, and we, the more senior people who are more in the realm of training younger people, will need to be adaptable to this idea. Not to mention the fact that somewhere along the way, robotics may come into our field as well, and we'll just see how that all plays out, and where it'll find a niche in terms of sort of how will we know that robotics is doing a better job than humans, and where exactly will it be doing a better job? That is sort of yet to be seen. There's some recent publications in JNIS on different aspects of robotics. So clearly it's there, and we'll just see how it sort of evolves over the next 5 to 10 years. So in terms of 5 years, what are the marks you give to the world in terms of 5 years after EVT became standard of care? Do you say pass, fail, super good, not so good? What do you think?
I think pretty good, with remaining potential for improvement, I guess. And I
Well,
think,
yeah.
as you say, all the easy stuff has already been done. So now all that's left is the more difficult stuff, and that will require collaborative effort and will be harder and more difficult. But as you said, we're pretty good at working together, and there are many people interested in improving stroke care around the world. And if they all come together, it should be fine, I think.
Yeah, no, you're absolutely right that we made a lot of progress, but we still have a long way to go. So you can look at it as job security. I just want to end with one last thing in terms of this idea of democratization of access to treatment, which Bill Gates and Melinda Gates talk about a lot. So the other part one always has to remember is that many of the things that we talk about or do are actually probably not available to half of the human beings on the planet, or maybe more than half. I don't know the exact number. In fact, there was a recent article in New England Journal. Was written by a friend of mine from medical school days, and he talks about this idea that he's practicing in a rural part of India, where this 45-year-old comes in with an M1 occlusion, and from his clinical judgment, he knows exactly what's going on, and the patient slowly dies in front of him just because there is no access to treatment. And that is another thing that we just have to be cognizant of, that somewhere along the way, we have to pull everyone along. I don't know how that will happen, when that will happen, but yes, we still have miles to go before we sleep. So thank you, Johanna, and thank you, Jessica. Thank you, NeuroNews, for giving us this opportunity. I do think overall we live in a very exciting time. We're living through history, and I hope all of you stay safe during this time of COVID. Hopefully, this is behind us in the not too distant future. But yeah, think about simulation, think about PPE, think about talking to your team and making them sort of feel comfortable, helping them understand what their role is. And I'm sure we'll get through this COVID thing and come out at the other end stronger. So thank you.
Thanks.